Thank you, Shamila. Good morning, everybody. Good evening, everybody. So my slides stopped moving. Hold on a minute, please.
ආරංචි උදව්වට.
Excuse me, please keep your mics muted throughout the presentation.
Shamila, is it possible for you to move from the other end? That it got stuck and it is not moving from this end.
Did you share your presentation?
I think she shared to Anushka. Anushka. Oh, Candy, all the participants mute your mics, please.
Not received your presentation. Dear participants, hope you all can hear us. Please keep your mic muted.
Anushka, could you please?
Yes, I'm going to my email now, madam. Give me 1 minute. I will share.
You can start, madam.
Is there a slide before that, Anushka?
Yeah.
Okay, we can start from here. So the objectives of this presentation and the outline of the presentation, I will just talk to you. I will discuss the anatomical and physiological differences of pediatric cases. Is it possible for you to hear?
Yes, we can hear Champika and can see the slides.
All right. Sorry about the delay. So that outline of my presentation of pediatric anesthesia and the objectives are to know about the anatomical and physiological differences of the pediatric age group compared to the adult, preoperative preparation of these pediatric patients, and pain relief and fluid balance, and the special equipment we use in pediatric practice, and with special emphasis in heat conservation. And I'm going to focus on few special problems encountered during pediatric practice. Next slide, please. So the pediatric patients there are differences in the anatomy, there are physiological differences and psychological changes are there compared to the adults, and pediatric age group can be classified into premature patients, that is born before 37 weeks of gestation, and neonates are the babies born from birth to 28 days after birth or 44 weeks of post-conceptual age. That infants are categorized as from 28 days to 12 months, and the children are from 1 year to 12 years, and adolescents are from 13 years to 16 years. There are anatomical differences in pediatric age group compared to the adults. They have a large body surface area, which causes that significant heat loss from their large surface area, and large head, large occiput, and large tongue, which makes the intubation difficult. And they have a high glottis, and the epiglottis is a long, narrow structure, and the larynx is anterior and placed at a higher level, that is at C4-5 level, and the cricoid is the narrowest part of the airway and prone to edema. That slightest damage to the mucosa makes the edema worse, and the intubation become difficult because of these anatomical changes. So in pediatric population, as I mentioned, the cricoid is the narrowest part of the airway. The significance of this is, even though the endotracheal tube passes through the glottis, there may be a narrowing lower down, so that you should not try to forcefully pass the endotracheal tube. As I mentioned before, that any trauma to the airway causes edema and increases airway resistance. So this slide shows that they have got a large tongue, and the pharynx is smaller, and larynx is placed anteriorly and at a higher level, and the narrowest place is the cricoid, and trachea is a funnel shape, and intubation that you have to do carefully and try to select the correct size endotracheal tubes. Next slide, please. And these children, they have got a short trachea that is about 4 centimeters. Because of that, the endobronchial intubation is possible, and the airways are narrow, causes high airway resistance, and the ribs are horizontally placed, which makes the less so no bucket handle movement. That is during breathing, they can't increase the anterior posterior diameter, so that the tidal volume is mainly by the diaphragmatic movement. So diaphragm is horizontally placed and that it can get splintered with abdominal dissection. As I mentioned, the trachea is short, endobronchial intubation is possible. So trachea divide at equal angles. So intubation could be either left or right. Not that as compared to the adults, that usually what we say that in adult population, mainly that endobronchial intubation occurs to the right bronchus, but in pediatric patient, it could be either right or left bronchus as it divides at an equal angle. The physiological differences when we consider that they have small functional residual capacity, that is oxygen stores are limited. At the same time, they have high oxygen consumption. So in the presence of small oxygen stores and high oxygen consumption, what will happen? The safe period of apnea would be low. So their airways are very sensitive. The laryngospasm occurs commonly during intubation as well as at the time of extubation. So we have to learn how to manage laryngospasm. So their airway, excuse me, could you please go back to the previous slide? So early airway closure occurs within the tidal breathing. So during spontaneous breathing, positive airway, the CPAP has to be applied. So you should not keep the patient just on spontaneous respiration without supporting. That CPAP has to be given, applied during spontaneous breathing. So respiration is, minute ventilation is mainly dependent on the respiratory rate. So induction and recovery is rapid. So apneic spells can occur, and that apnea is considered more common if the gestational age is less than 6 weeks. The respiratory center is immature, that they are more prone to respiratory infections, and mainly they are obligatory nasal breathers till about 5 months. So upper airway, upper respiratory tract infection can cause the blockage of the upper nostrils and upper airway, making increased resistance to breathing. We continue the physiological differences in this age pediatric population. Their blood volume, when we consider their blood volume, neonate has about 90 ml per kg blood volume, and the infant's blood volume is about 85 ml per kg. Child's is about 80 ml per kg. So cardiac output is rate dependent, and bradycardia is common, and it is considered when the heart rate is less than 100 per minute. So as I mentioned, the cardiac output is mainly rate dependent, and any bradycardia causes reduction in cardiac output. Bradycardia is a common response to hypoxia, hypotension, hypothermia, and vagal stimulation. Heart, the stroke volume is less contribute for cardiac output. Ventricular muscles are not well developed. They are having low cardiac calcium stores, and cardiac output is rate dependent, and they are having physiological shunts. So these shunts are not anatomically closed at the time of birth, that there is only the physiological closure of shunts. They may be having patent ductus arteriosus, ASDs, which can get opened up with increasing pulmonary resistance and pulmonary hypertension, which occurs with hypoxia, hypercarbia, acidosis, and with hypothermia. That shows that they are having flip-flop circulation. Heart rate is variable with age, and bradycardia results in hypotension. And blood pressure we consider as normal in the sense that the blood pressure also ranges with the age of the patient. So normally we consider the systolic blood pressure of 70 to 90 and the diastolic of 50 to 70 as normal. That is the inference. Physiological differences, when we continue, the kidney is immature and that they have less ability to concentrate urine and produce diluted urine. So their filtration and clearance is reduced, causing delayed drug excretion. So we have to time the drug doses accordingly. Liver metabolism is also, liver is immature and metabolism of drugs may be affected. So especially the phase 2 metabolism get impaired. So their glycogen stores are reduced and immature glucose homeostasis making them more prone to hypoglycemia. So we have to monitor blood sugar during prolonged surgery and may need dextrose infusions, and we should not make them hypoglycemic by keeping prolonged fasting. Central nervous, when we consider central nervous system, their blood-brain barrier is more permeable in neonate, causing increased sensitivity to barbiturates and opioids. And temperature regulatory mechanisms also not well developed. I will discuss the temperature regulation separately during the course of our lecture. So I discuss now the anatomical and physiological changes in pediatric age group. Keeping these changes in mind, before going for surgery, we have to do proper preoperative assessment of these patients. So when we consider the preoperative assessment, we have to take a good history of the patients. We should get the patient's birth weight and the mode of delivery, the period of gestation at the time of birth, and the maturity of the baby, and whether there is adequate weight gain. So immunization history also has to be considered, whether they have been immunized recently, to decide whether we have to postpone routine surgeries or not. Medical illnesses, they are more prone to get bronchial asthma, and there may be history of convulsions, respiratory tract infections, and they may be having congenital heart disease, and we should get any history of medication, whether the child is on any bronchodilators, any cardiac drugs, or any medication for convulsions, and so on. Allergic history is also important, and we have to get the history of any previous anesthetics and whether there is any complication associated with the previous anesthetics. And if the child is coming for the first time for any surgery, we have to get the family history of any anesthesia related problems, whether the child was diagnosed of having any special syndromes, because pediatric population we come across children with lot of syndromes, and we have to identify whether they are having any problems associated with these syndromes. And adequacy of fasting we have to check. So as for any patient, that we have to get the ample history. So examination wise, we have to check the patient's general condition, whether the child is pale, whether the hydration is adequate, whether the child is febrile, any cardiovascular problems, the heart rate, rhythm, and any murmurs, any special additional murmurs we have to check. And if if you detect any murmur, we may have to consider getting a 2D echo done. So respiratory system, we have to examine and see whether active infection is present or not, or any current evidence of bronchial asthma. Airway has to be assessed properly, but not like in adults that sometimes that it will be difficult for us to get the malempathy screening, and you have to see whether there are any loose teeth and any syndromic features which make the airway and intubation difficult. So IV sites need to be checked whether the cannulation is going to be difficult. And back, we have to, if we are planning to give a caudal block also, so we have to check whether there is any abnormality in the back. Investigation wise, that we usually don't do any investigations in pediatric age group unless the history and examination indicates any problem. So in our setup, that we don't do any routine investigations for a child who comes for a mild to moderate surgery. So if the child comes for a major surgery, we do the relevant investigations. But if a child coming for circumcision, hernia, and so on, small or intermediate surgeries, we usually don't do any investigations unless the history and examination suggests any problem. So otherwise, for major surgeries, we do full blood count, blood urea serum electrolytes. If necessary, that we consider doing coagulation profile. And if there is any evidence of chest infection or any respiratory symptoms, we consider doing chest X-ray, and any evidence of murmurs, consider doing a 2D echocardiogram. So once you do the history and examination, and if necessary to do the investigations afterwards, what we have to do, we have to prepare the patient for surgery. How are we going to prepare? So if the child is having any medical problems like bronchial asthma, respiratory problems, that if it is not an urgent surgery, that if there is time, we have to optimize the medical problems. So normally we don't pre-medicate these children unless it is indicated. So atropine can be given if there are a lot of secretions. Oral midazolam is considered in selected patients, but if we give any sedative pre-medication, we have to monitor these children closely. So in our setup with lot of patient load, and there are no specific area for us to monitor these patients before going to the anesthesia, Normally, we don't consider, as a routine, we don't consider any sedative pre-medication. Fasting guidelines. So we give clear fluids 1 to 2 hours before surgery. What do you mean by clear fluids? What can you use? You can consider Jeevani, that is oral rehydration fluids, plain tea, or any clear fluid which you can see through. So 1 to 2 hours before the surgery, you can consider giving clear fluids, but it is not the liberal fluids that we have to limit it to 3 ml per kg. Breast milk can be given 3 to 4 hours before surgery, and formula milk and the solids need to be stopped 6 hours prior to surgery. That local anesthetic, So EMLA cream, that is the local anesthetic patches, can be applied in patients with difficult IV access, or the children who are scared of needles. So the EMLA is good. Local anesthetic patches are good, but routinely we don't apply due to non-availability. Freely it is not available in all the places, but in selected patients, if they have needle phobia, or in selected patients, we can consider applying the EMLA patches, local anesthetic patches. If child is coming for a major surgery, and if we have to keep the patient fasting, so IV fluids need to be started. So it has to be crystalloids with added dextrose to prevent hypoglycemia. And for the children who are waiting for major surgery, ICU HDU bed has to be reserved preoperatively, and informed written consent has to be taken from the parents or the guardian. Children with suspected dehydration, so we have to assess the level of dehydration. So children who come for laparotomy, intestinal obstruction, appendicectomy, and any sort of child who is coming with suspected dehydration, we have to assess the degree of dehydration. It can be assessed clinically by their behavior, thirst, mucous membrane, so anterior fontanelle, skin turgor, urine output, and pulse rate and blood pressure. So, and according to these clinical features, the children can be categorized into mild, moderate, or severe dehydration. If the dehydration is mild, the percentage dehydration is considered 5, and if it is moderate, 10% dehydration, and severe, the percentage dehydration is 15. So special changes in these different categories. In mild dehydration, normally there is not much changes in the clinical parameters, except the slight increase in thirst and the urine output. In pediatric patients, the normal urine output we consider as 1 to 2 ml per kg compared to 0.5 to 1 ml per kg in adult population. So in mild dehydration, there may be a slight decrease in urine output, that is less than 2 ml per kg per hour. And in moderate dehydration with 10% dehydration, so the urine output would be less than 1 ml per kg, and the child may be tachypneic and the blood pressure may be low. And in severe dehydration, child, apart from the cardiovascular changes, child may be lethargic and conscious level may be low. The child may be irritable, lethargic, and urine output would be significantly low, and it may be less than 0.5 ml per kg per hour. So according to this categorization, we consider the fluid loss is about 50 ml per kg in mild dehydration. Moderate dehydration, the amount of dehydration is about 100 ml per kg, and in severe dehydration, it's about 150 ml per kg. That is how we are going to calculate the fluid deficit, and this deficit is we correct this deficit over 24 to 48 hours unless the child is in shock. If the child is in shock, we consider giving 10 to 20 ml per kg boluses. 2 to 3 such boluses are given and try to correct the dehydration depending on the severity of dehydration. So, fluid balance, they become, as I mentioned earlier, that their body surface area is high, they become easily dehydrated, and they become easily dehydrated, and as the heart can't cope up, the compliance is low, and they cannot cope up with overhydration as well. So we have to meticulously manage the fluid status. So I discussed how to correct the fluid deficit. So fluid deficit usually we correct with crystalloids, normal saline, no Hartmann's, and the maintenance fluid we calculate according to Holiday and Sega equation. That is, for the first 10 kilos, we use 10 ml per kg per hour, and the next 10 kilos, 2 ml, we add 2 ml per kg per hour to the previous 4 ml per kg per hour fluid, and more than 20 kilos, we add 1 ml per kg per hour for subsequent kilograms. The sodium requirement is about 2 to 3 millimoles per kg per day, and the potassium requirement is 1 to 2 millimoles per kg per day, and the replacement volume in dehydration is body weight into percentage loss into 10. Okay. So what are the fluids available for replacement and maintenance? We can use 0.9% saline, Hartmann solution, or half normal saline in selected patients, and patients who are fasting, that we can use crystalloid solution with dose. So these are the fluids which we can use, that normal saline and triggers lactate are the things which we use normally. And normally we use the burette sets to give accurate fluid volume, to prevent overhydration, and to give the necessary amount of fluid. Especially the children less than 10 kilos, we have to use the burette set for the fluid replacement. And fluid has to be given via warming devices to prevent hypothermia. So blood volume is higher in children, as I discussed earlier. Test 90 ml per kg, and child has about 80 to 85 ml per kg. And when the blood loss is more than 10% of the blood volume, we have to consider replacement. So there's a calculation that if we say the child is 10 kilos, the total blood volume is how much? For a child, 80 into 10, 800 ml, and blood has to be replaced when the blood loss is about 10% of the blood volume, that is about 80%, 80 ml blood loss, we have to consider blood transfusion. And the pediatric equipment, we have to specially select the correct size airway equipment. Face mask has to be selected the correct size, the smallest possible face mask which fits to the child has to be selected to prevent the increase in dead space. And breathing circuit what we use normally is the Mapleson F circuit for children less than 20 kilos, and Mapleson T for the children more than 20 kilos, and the circle system with pediatric tubing can be used if it is available. So usually we prefer smallest possible transparent face mask. If the fruity smelling masks are available, that children may use it happily. So oropharyngeal airways, the sizes according to the body weight of the child. So it could be 000, 000, 0, 1 or 2. And the laryngoscope has to be selected according to the age of the child. And for straight blade laryngoscopy scopes for the neonates, and curved or Macintosh blade laryngoscopes for the bigger children. And if the video laryngoscope is available, you have to be ready with the video laryngoscopes. ET tubes, normally conventionally we use uncuffed tubes, but nowadays that even the cuffed tubes are available. And if it is available, the children more than 3 kilos cuffed and endotracheal tubes can be used. And for neonates, the size of the tubes are 2.5, 3 or 3.5 for neonates, and infants, the correct size is around 4, and always you have to keep 1 or 2 sizes above and below the size of the child. And how to calculate the size of the tube: age divided by 4 plus 4, and the length is age divided by 2. There is a small mistake that it has to be age divided by 2 plus 12 for oral tubes, age divided by 2 plus 15 for nasal tubes. And we have to avoid catheter mounts to reduce dead space. So like there's a range of airway equipment. Depending on the size and age of the patient, we have to keep correct size laryngoscopes, airways, face masks, and if we have to pack the and throat, that be ready with the throat packs and the Magill faucet. And ambu bags has to be ready all the times. Better if you have the ambu bags with the reservoir bag and the suction catheter and the stethoscope. You have to always be ready. This is a Mapleson F breathing circuit, which you are familiar with. So the Mapleson F circuit, dead space should be minimal, and the length of the child and the tip is the dead space. And corrugated tube, the internal volume has to be greater than the tidal volume of the child, and the reservoir bags, usually for pediatric age group, is about 500 ml. So recommended fresh gas flow, the minimum fresh gas flow is 3 liters per minute, and it has to be not 30 to 50, it has to be 50% oxygen. Usually we consider giving for pediatric patients. And the drugs, you have to be ready with according to the patient's weight. We have to calculate the correct dose and draw the required amount and keep it labeled. So heat conservation is a problem. We have to prevent the heat loss. So hypothermia is poorly tolerated. It causes respiratory depression. Cardiac output can become low, and there may be platelet dysfunction, and they may become more prone to infection because the leukocyte activity can get reduced, and even severe hypothermia can cause cardiac arrest. So to prevent heat loss during surgery, we increase theater temperature to 24 to 24 degrees centigrade and use warming blankets on the operating table. Fluids are given via warming devices. Cover the head with cotton wraps. Minimize exposed areas and minimize the duration of exposed time. And saline wash has to be warmed, and irrigating fluid has to be warmed to 37 degrees of centigrade. So regional anesthesia, especially the coatal anesthesia, is commonly used in pediatric population because it gives a very good post-operative, intraoperative and post-operative analgesia in children. So it has to be done under general anesthesia, and with the caudal analgesia, the recovery would be smooth, and it reduces stress response to surgery, and it is better for surgeries below T10, but it can go even up to T6 level. So before doing any caudal or regional block, you have to be ready with emergency drugs. Atropine, you have to be ready with 0.02 to 0.04 milligram per kg, and ephedrine 0.5 milligram per kg. And we use the plain bupivacaine 0.25%. If we need to get the analgesic level up to L1, that is the inguinal region, perineal blocks, like for circumcision. So you use 0.5 ml per kg of 0.25% bupivacaine, and the level, if we need to get up to T10, like for hernia surgery, we can get the 0.25% bupivacaine 1 ml per kg, and if we consider having the analgesic level above T10, so we have to calculate the safe dose of analgesia, that is 0.5% bupivacaine 2 ml per kg, and it can be diluted up to 1.25 ml per kg. Then the consideration of local anesthetic become less than 0.25%. So the technique of giving caudal, it has to be done as a sterile procedure. You have to scrub up and wear the gowns, sterile gowns. It is done under after general anesthesia, and somebody should monitor the patient. Monitoring has to be applied. Position the patient in lateral position with the hips and knees bent at 90 degrees, and we have to feel the triangular sacral hiatus and pierce the skin perpendicular and avoid 45 degrees angle as in adult. So we give perpendicular to the skin. Always aspirate to exclude CSF or blood, and inject local anesthetic agents, and halfway also you stop giving the drug and re-aspirate and give the second half of the drug. So we'll now discuss a special problem. So this is a bronchoscopy, that even though we say that it is done in specialized center, better for you to know how to do the bronchoscopy, because that it may come as an emergency. So it may be a diagnostic or therapeutic. It may be for foreign body removal. So preoperative assessment as for other patient, but with special concern for respiratory system. We have to check whether the child is dyspneic, tachypneic, and whether the child is sinus or hypoxic, and check whether the lung signs are present, whether the airway air entry is adequate on both sides or only the one side air entry is absent. And chest x-ray, check whether there is any consolidation or collapse due to the presence of foreign body. And then IV access has to be established, and it may be under anesthesia, and already child may come with an IV fluids in place, and the child and parents all are anxious. Child may be in full stomach if it's emergency foreign body removal, and special consideration is this of this condition is a shared airway condition. We have to share the airway with the ENT surgeon. So normally what we do, we apply the monitoring and induce the patient with gas induction, maintain spontaneous respiration as much as possible. When the surgeon insert the bronchoscope, if it's a for a ventilating bronchoscope, we can connect the gas flow via the side port of the bronchoscope and maintain anesthesia. So we have to monitor the patient very carefully for desaturation or bradycardia. So dexamethasone 0.1 milligram per kg is given to prevent postoperative laryngeal edema. So once the procedure is over, so we have to maintain the airway until the patient wakes up. And postoperatively, there we have to check whether the child is having bronchospasm, stridor, or whether the child is getting hypoxia. So we'll consider another problem. This is a child who is coming for circumcision. So we'll discuss how can we give the analgesia or any other surgery. We'll discuss briefly how can we provide perioperative analgesia for patient coming for surgery. So pain relief has to be multimodal and start from simple analgesics. So paracetamol can be given 15 milligram per kg and maximum dose is 90 milligram per kg in divided doses. It can be given orally, per rectal or intravenously, and dose can be given 6 to 8 hourly. The other option is the non-steroidal anti-inflammatory drugs, diclofenac sodium that can be given 1 milligram per kg per rectally twice daily. Ibuprofen dose is 10 milligram per kg, 8 hourly can be given for children more than 1 month, and the non-steroidal diclofenac sodium can be given for children more than 6 months, provided child is not having any contraindication for non-steroidal anti-inflammatory drugs as bleeding, active bronchospasm, but history of bronchial asthma is not a contraindication for the non-steroidal anti-inflammatory drugs. So opioids, we can consider short-acting opioid like fentanyl, 1 to 2 mics per kg, and morphine can be given 0.1 milligram per kg, and pethidine is normally, we don't use it very much during the theater, but in ward setup, pethidine is the drug they are familiar with. It can be given 1 milligram per kg. Remifentanil if it is available, can be considered 0.05 to 0.2 mics per kg. And the regional techniques like infiltration and regional blocks can also be considered. So for any patient, we have to give multimodal analgesia and we have to assess the adequacy of analgesia post-operatively. So we'll consider another problem commonly encountered in our pediatric practice. What is this? The child with the upper respiratory tract infection. So most of the children have the history of upper respiratory tract infection. So what is the average? They get about 7 episodes of upper respiratory tract infection per year. We have to consider whether the child is suitable to go for surgery at this moment or whether we have to consider postponing routine surgery before so what's the significance of having upper respiratory tract infections? Airways are become hyperactive and hypersensitive for weeks after having upper respiratory tract infection. So it is about 6 to 8 weeks. The airways are hyperactive. So what's the significance? It increases perioperative respiratory complications. A child with upper respiratory tract infection, we have to assess them meticulously. Need to get the history of purulent nasal discharge, productive cough, presence of dyspnea and systemic effects of infection like lethargy, poor feeding, and parental confirmation is the better way of getting proper information. We have to check whether the child is febrile, whether the temperature is more than 38 degrees of centigrade, whether the child is having active infection, presence of bronchospasm, any breath holding attacks, that we have to check the nostrils and oropharynx, whether it is inflamed or presence of tonsils, and if necessary, taking chest x-ray and checking CRP, WBC count would be useful to decide whether the child is having active infection currently or whether we can consider going for surgery. The goals of assessment is to minimize secretions and avoid or limit simulation of potentially irritable airway. So airway should only be suctioned under deep anesthesia. If we decide to go for surgery, airway suction has to be minimal and it has to be done only under deep anesthesia, and child should be well hydrated, and humidification of gases may be helpful to clear secretions and prevent mucus plugging. If the child was on any bronchodilators, ipratropium bromide or any other bronchodilators, better to give the bronchodilators 10 to 30 minutes before induction of anesthesia, and tracheal intubation has to be avoided if possible, and laryngeal mask airway or face mask are preferable, and better to lubricate the airway equipment.